Hi, this is Brian Kim. I'm going to share with you this case of a patient who is a very high myope and the worst reverse pupillary block I've ever seen. So I've seen a lot of pupillary blocks, and I normally see them when I'm doing the Phaco or IA, when you go with that high infusion pressure from the machine. But this is really unusual because it happens when I'm doing hydrodissection. And so we're going to talk about, why does this happen? Now, it's a combination of things. It's usually in the high myopes, which means they tend to have reduced scleral rigidity. They also have loose zonules and sometimes a little bit of a floppy iris. And so what happens is you increase that anterior chamber pressure, and it causes the iris to tamponade against the anterior lens capsule. And when the iris is 360 degrees sealed and pushed back on the anterior lens capsule, that causes immense anterior chamber pressure, and it pushes the entire lens back. And when it does that, it causes stretching of the zonules and the iris as well, and the pupil gets really large and the pressure goes up. In some patients, because of that reduced scleral rigidity in these high myopes, they can experience immense pressure. And of course, that translates into pain. And so you're going to see that in this case, again, not during Phaco, not during IA, where you normally see this, but during the hydrodissection. And this is the first time I've ever seen this. And of course, I'm going to show you how you should alleviate reverse pupillary block. So this is a patient. You can see there's a little bit of a Bell's reflex, and I'm using the cotton tip to steady the eye and center the eye and use a corneal marker, which will help me to center and size the rhexis. I make my paracentesis incision first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. Using the cotton tip to hold the eye downward, I push some epinephrine and then some dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. Using that cannula to hold the eye and control it, this is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove tunnel, and then I enter. And I'm using that cannula to hold the eye because if I don't, the patient's going to look up. And so this is a right eye case. Using the cannula through the paracentesis incision is quite advantageous and quite easy to control the eye in an indirect manner without having to grab it with forceps. So these are the sharp tip Haldane-Pericard forceps. I puncture the center, pull down, and create a tear, grabbing the right side of the tear, going around circumferentially, grabbing and re-grabbing. And the beautiful thing about having that dispersive viscoelastic cannula there is if I have to and I feel like the chamber becomes unstable, I can directly push more dispersive viscoelastic with this same cannula that I'm using to control the eye from the Bell's reflex. I burp some viscoelastic out. And this is the capsular fornix hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, point the tip down, but look what happens. As I try to make the wave, look at the pupil. It gets large and the patient starts to move. So I'm going to show you that again. You can see the pupil enlarging, the chamber is deepening, and the patient is wincing and she's verbalizing she's having pain. And so when this happens, I stop, and you have to release the pupillary block. And so what is a reverse pupillary block release mechanism? You have to lift the iris. So when you lift the iris, you equilibrate the pressure between the anterior and posterior chambers, and then the patient should have relief of that pain. So I go ahead and lift the iris here, give the patient some relief, and then very carefully I go back and try to finish off hydrodissection. You can see the nice wave that I finally get. You can see that the pupil didn't expand and the chamber didn't deepen, so I did not cause reverse pupillary block again. I'm very carefully trying to rotate the lens, freeing up the anterior capsule with the cannula, and then the lens begins to spin. So I lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. And before I activate irrigation, remember that's a high infusion pressure, I'm going to go underneath the iris with the chopper before I initiate irrigation. So I lift with the chopper on the iris, and then I turn on the irrigation, and I was able to avoid the reverse pupillary block. I place the chopper around the lens equator, contra-incisionally, the phaco-tip vertically, sub-incisionally. Fracture the lens completely in half, that's double chop. I place the chopper around the right heminucleus, hooking the peripheral lens, pulling it centric toward the phaco-tip, crushing it against the phaco-tip like it's a chopping block, and that is a cross chop. Lifting that first quadrant up with some vacuum, and then it just falls apart. It's a pretty soft lens. Turning the lens, lifting that second quadrant up with the chopper, and then emulsifying the lens piece. Rotating the second heminucleus in front of me, placing the chopper around the lens, pulling it centrally toward the phaco-tip, which is deep between the lens pieces. Again, I'm crushing the lens with the chopper against the phaco-tip as if the phaco-tip is a chopping block. It's such a versatile technique. Doing the same maneuver against that fourth quadrant, and the lens is emulsified. Using some vacuum to grab the epinuclear rim, which pops up and it just collapses. Very easy lens removal technique in this case. So I take the chopper out, push BSS in, take the phaco-tip out, and I go in with the INA handpiece. But listen, before I activate infusion, I lift the iris with the cannula. So you don't want to just go in now and turn on infusion. The iris is going to go back. It's going to cause that immense infusion pressure and cause the reverse pupillary block. So now what I'm going to do is use the INA handpiece tip to lift the iris and then turn on infusion. You see that? And so now the reverse pupillary block was avoided by doing that maneuver. So with infusion on, because you don't want to stop it, once you start, you have to keep the infusion on in order to prevent further reverse pupillary block. And you'll know what I mean in just a moment. So I start to remove the cortical material from anterior to posterior, peeling it, and this is fairly routine here, polishing underneath the rexus edge, removing any potential lens material, as well as cleaning the lens epithelial cells. I'm polishing the posterior capsule. Again, this polymer tip is so nice in that way. Polishing the posterior capsule, polishing under the rexus edge once again. The thing about reverse pupillary block is if I stop infusion and you start again, it can trigger it immediately once more. And so you have to sustain the infusion pressure once you've stopped the reverse pupillary block. So I pulse BSS into the subincisional area. And then this is a cohesive viscoelastic. I'm pushing it into the bag, turn off the infusion, and I'm able to preferentially dilate the, you can see how stretchy the iris is. Again, it's a combination of those things, a stretchy iris, almost like it's floppy, but it's not really a small pupil, but it has some elastic quality to the iris. And that's, again, part of why you get that reverse pupillary block. And it's also why not every high myope gets reverse pupillary block. And so go ahead and polish underneath the rexus edge, first on the left side and then the right side, removing the lens epithelial cells. And this is a single piece acrylic lens. It's going to go into the capsular bag. I'm able to turn the eye away from me to be able to visualize the rexus edge, making sure that the leading edge of the lens is going underneath the rexus edge. As the lens unfolds, I go ahead and quickly transition to IA, but remember, I got to lift the iris. So lift the iris, activate irrigation. I was able to stop the reverse pupillary block, go underneath the lens, lifting it and tilting it, rotating it 90 degrees clockwise, removing all the viscoelastic from within the bag. Putting the optic back in, polishing under the rexus edge. And this is what I mean by sustaining that infusion pressure. I'm going to go ahead and switch to visco, remove all the viscoelastic from the anterior chamber. And this is what I mean. When you sustain that infusion pressure, it's able to keep the reverse pupillary block from happening in that moment. But you have to sustain that pressure. Look what happens here. I'm ready to come out, but then I see a small piece of lens fine lens material underneath the IOL. And so I choose to go underneath it. I turn infusion off for a moment and I turn it back on, and look what happened. This patient had immense reverse pupillary block pressure. You saw the pupil get big, the chamber deepened. And in that moment, when I turned off infusion and I went underneath the lens to remove that fine lens material, and then I activated it once again, you saw it trigger. And so again, that's really very important. You have to sustain irrigation, that high infusion pressure all throughout. Otherwise, you can trigger another reverse pupillary block. Again, a crazy case. I've never seen causing a reverse pupillary block and triggering pain when I'm trying to get underneath the IOL to remove the fine lens material. I've never seen that. This is the first time I've ever seen triggering reverse pupillary block during hydrodissection and when I went underneath a lens to remove fine lens material. I mean, you would think, oh, I'm underneath the lens, it shouldn't do that. But it goes to show that's not how it works. And so this is very important. In order to prevent reverse pupillary block, once again, at the very end of the case, you have to use a cannula to lift the iris and then sustain that infusion pressure as you come out. And so again, you see I'm getting underneath the iris, making sure I'm going to prevent reverse pupillary block. And as I come out, I'm going to sustain infusion pressure as I withdraw the cannula the entire time. And it has to be a steady, firm infusion pressure with the cannula, with the BSS as I come out. And I'm going to show you that here. See, pushing BSS, come out, come out, come out, come out. And then quickly, and when you do it like that, you'll feel that the eye is nice and firm right now. And this is another thing. As you burp out the BSS, if you go too low again with the pressure and you want to fill it again, you can't just go in and push some more BSS. You will trigger potentially another reverse pupillary block. And so the way you handle that, you'd have to do what I just did all over again. Again, you have to fill the eye if you want to, go in with the cannula, lifting the iris and pushing with firm infusion pressure as you withdraw the cannula out of the eye. And so in this case, I didn't have to do that because I didn't want to do that again. I have a nice firm eye, burping little by little, and this is the end of the case. So again, extreme reverse pupillary block. You saw, again, just with hydrodissection and when I went underneath the IOL to remove some fine lens material, it caused that sudden triggering. The pupil got huge, pushing against the anterior lens capsule, the chamber deepened, the patient winced and cried out in pain. And again, this doesn't happen to every high myope, but it's a combination of zonular laxity, that reduced iris tone, and that flaccidity of the iris. All of that in combination causes this situation. Again, if this was a retrobulbar case, a block case, you wouldn't worry about this, but any topical case you have, you're going to run into this situation. And again, this is the most extreme, worst case that I've ever seen a reverse pupillary block. And hopefully this illustrated some of the concepts of how it happens and why it happens and how you're able to mitigate it, avoid it, and then if it does happen, how to handle it. So I hope this was helpful to you, and I thank you for your attention.